just go a little bit further into chapter 43, or what is the other?
40.
40. Yeah. Now let's get a little bit even sadder. It depends. I mean, they're all sad. And I think the main thing is making sure that we have the psychosocial taken care of with all of these. And you've got to take care of the family as well. And no, because it interrupts everybody's life. I mean, how would you feel as the son of the lady that had Huntington's? You know, mom can't hold the birthday party like everybody else did. Mom can't take him, and he has to have rides places, or maybe he can't be a part of the football team because he can't get there every day.
And that whole genetic component.
Uh-huh.
I mean,
Just knowing.
it's a genetic disorder. And you see it in families that having genetic counseling would be wise.
Right. Or then the patients with Alzheimer's, you know, they can no longer be left. You've got all that extra. Same thing with Parkinson's. It's very debilitating. And we've got to take care of our families. All right. So chapter 40, or 43 in the other book. Care of the patients with problems of the central nervous system, the spinal cord. All right. Priorities for this chapter are immunity. You know, one of them we're going to talk, a disease process, is MS, multiple sclerosis. You know, is with immunity. It's big. Mobility. We're talking about our spinal cord injuries. Sensory perception. This specifically is for both of them. The interrelated concepts in this chapter are comfort, so we want to keep them pain-free. Cognition, sexuality is important, and also sensory perception, so you might want to add that to your list. All right. This big first one, the immunity concept exemplar, multiple sclerosis. Has anybody met somebody with MS? Okay.
My grade school PE teacher.
Grade school PE teacher.
Yeah.
So a very active individual.
She tried to be, yeah.
She did.
She had braces
Mm-hmm.
she would walk with. And I think progressively it's gotten worse for her over the years. I mean, this is 25.
So she didn't walk with braces when she became a PE teacher, I'm guessing.
That I don't know.
Probably, yeah.
Probably not.
Probably not, yes. Well, at least she was still working and still going.
Mm-hmm.
Yes, but it was. It was hard to see her struggle, wasn't it?
Yeah.
So did you give her a hard time, or were you a good kid for
No, we were pretty good for it.
Pretty good, okay.
Yeah.
Just checking. Sometimes people take advantage of that. All right, this is a chronic disease characterized by the demyelination and axonal nerve damage. So there's 4 types, okay? The most common is the relapsing and remitting. So especially when they first start out, you can see this happen. They talk about it, they go into relapse. They might have to change their medication. And the relapse is all of a sudden they've lost vision. What other type of things can happen? They might lose bladder control. There's something different. It could be sensation. They're not able to swallow well. There's all different kind of things, but that it can get better. Okay, so it'll be remitting and coming back to normal. That's the most at first. The next one is primary progressive. This usually happens if they're in between the ages of 40 to 60. And this is a steady decline. They do not get that chance to get those things better. Okay? The secondary progressive. This one, the secondary progressive one, has the remitting. They will relapse and remit. So they'll get better, and then it'll continue to decline. It'll get a little bit better, maybe half better, and then it goes worse again, and less and less better. And the progressive relapsing, they might have some recovery, but they don't ever get back to baseline. Okay? This happens. It's immune, it's genetic, and it's in young and middle-aged people. All right. interprofessional collaborative care. Okay? We have to, the assessment, we have to notice what's happening with them. And is it MS or is it ALS? Okay? So they can mimic at first, but if they don't have the same ending. What do we know about ALS? ALS is 100% fatal. ALS is a progressive neurodegenerative disease, and it affects the neurons in the brain and the spinal cord. So ALS is what percent fatal?
100.
It's horrible. Yep. And we'll have a good video on that. Okay. MS, I do want you to look at page 873 in the bottom corner. Look at all those things that can happen. Talked about difficulty swallowing, difficult speaking due to the slurred speech, the tinnitus, the ringing in the ears, vertigo, the dizziness, changes in the peripheral vision, muscle weakness, spasticity, fatigue. They're trying to do something, they're trying to reach for something, and they just get a intentional tremor. What other looks horrible on there if you were to have MS? None of them want that bowel and bladder dysfunction. They definitely don't want to have the sexual dysfunction. That causes big problems in marriages. Depression's going to happen almost with all of them. But if you look at that list of all the things that can happen, a lot of things to assess, a lot of things to take down. So for our physical assessment, head to toe, you'll see lots of different things. But remember, Betty Sue's MS might not be the same as Susie Jane's MS. They're going to have different type of things and at different times. Psychosocial assessment. What do we say this patient most likely? What do we think is going to happen? Depression, yes. And the laboratory assessment, there's no single test for a definite diagnostic test for MS. How do they typically find it? Anybody know?
I would just say the drop dish.
Okay.
Because of the demyelination, they have trouble with grip, and they'll start breaking dishes and not know why.
Mm-hmm.
That was in the past.
The drop dish.
Elimination.
And they can find it on a CAT scan too. They'll find the spots. And sometimes...
But when you first, why would you go have a follow-up? You start breaking, you have a grip
Right.
problem.
All right. Other diagnostic is your MRI of the brain and spinal cord as well. Interpreting. Let's see here. The problems would be potential for infection. They have decreased immunity because of the disease and the drug therapies. They're not able to be as mobile due to spasticity, tremors, and or fatigue, and decreased visual acuity and cognition due to the central nervous system dysfunction. I have a cousin, she just passed away this last year. She really did very well with MS. She was diagnosed after her second pregnancy, second baby was born. So she was in her 30s. She actually lived to be 79.
That's astonishing.
Astonishing. She had great care from the family. And, I mean, she had been wheelchair bound since she was in her 50s. And her biggest thing was she would constantly have bladder issues and infections and then fevers, and it would go systemic and she would get septic. But she had care in the home, and her husband, who loved her dearly, went ahead and he built this big porch like twice the size of this room outside, so that every day they would get her outside. And he had flowers and flower gardens. And so you think he did so much for her mental aspect as well to keep her. You know, it was amazing what he was able to do for her. And you know, they had to get the handicap van. You had to have all the equipment. She was not a light person. He had to get a lift because he ended up having back problems. At first, he was a big guy, he was 6'7", so he just picked her up and move her. But eventually, that became too much for him with age too. So yeah, I mean, so you can live much longer. So my second cousin, her daughter, has a son and a daughter. Guess what she has? MS. But she started the interferon shots early, and so far she's doing very well. So we've come a long ways with MS and the treatment and the drugs.
What made them decide to see a neurologist?
It was after the baby. Her legs would give out, and she would fall.
Again, loss of strength.
Yeah, loss of strength.
Yeah.
That's what made her go the first time.
Right.
And one of the biggest things that, her name was Corrine, she loved to be outside and loved to be almost a sun goddess, a sun worshiper, and swimming and had her pool and everything. And you have to avoid the heat. So that became one of the things that she did have to give up eventually. So, you know, the heat will cause all that extra fatigue, things that you have to work on. Okay, purpose of management, modify the disease effects. So we're going to treat the areas that have problems, prevent exacerbations. One of them is by not being out in the heat, right? Okay. We're going to manage your symptoms. Where am I here? Improve their function and quality of life. We're going to at least maintain. Things that we can do is we can take them to a speech pathologist. Sometimes they're part of the team, not normally, for all the things we think about. What would they help with here? We looked at the list of things. So there were speech deficits, right? And they can also help with swallowing, which is a big one that affects all their nutrition. Sometimes in the hospital you might have to thicken the liquids so they're not choking. We don't let them have extremely rigorous exercise. They can have exercise, but rigorous exercise is not good for them. It's good to do the range of motion exercises and avoid the high temperatures. You said are hard on the body. Okay. Home care management. So, like I said, my cousin went ahead and he built a deck. They did things at the home to make it better. It does affect the whole family like the rest of these neurodiseases, and is often unpredictable in terms of disease course. The National MS Society has quite a bit of information out there. It's very, very helpful. Okay? Has anybody ever done any of the bicycle races or any of the marathons and different things for MS? They have several things out there. Any other things on MS before I go on? At least we've got some newer drugs and treatment, and it's, you know, we don't find it quite as debilitating. And like I said, she lived to be, 79? Which is quite amazing.
It is amazing.
Yeah, that doesn't typically happen.
No, that's not your typical course.
And she didn't die of that either. She ended up going in for a kidney stone.
Ooh.
And they messed up.
Immobility.
Well, yeah, she'd been
Immobility,
bedridden.
Calcium, then
Calcium,
leaks out,
urinary
and
retention.
hypercalcemia and stone formation.
Okay.
That's an example.
And then what happened was, surgeon messed up, and he perforated, and when he went in, somehow he nicked her aorta, and she bled to death. Isn't that horrible? Ugh. So, when you think of your patient going in for a routine surgery, and if this family's very nervous and upset, remember, they have a right to be upset. They may have had a family member that had something terribly go bad. They may have already had a family member that died in that same hospital. They were just up one floor, or they were just down the hall. It may have only been 6 months ago. So you never know what kind of trauma that person, what's happening with them. You always have to be cognizant of that. All right. Spinal cord injuries. We'll finish up at this part, and then we'll watch another video, okay? All right. So spinal cord injury, we are talking something that's going to go ahead that stop our function from wherever the injury is down, okay? We injure that spinal cord, we won't be able to move and do other things. So to happen what happens, the hyperflexion, okay? So hyperflexion, that's usually from a head-on accident. Somebody said you hit head-on, you go forward. Hyperextension is usually you're hit from behind, if somebody hits you from behind, okay? The axial loading or vertical compression is caused by, it could be by jumping or diving, or some people falling on your buttocks, like I mentioned earlier, breaking my coccyx, roller skating with the boys. Excessive head rotation, farther than it's supposed to go. I don't even want to try it, okay? So somebody, go ahead.
No, I worked at Russ Rehab, PRN, and they were talking about a case, a guy came in for assessment because when he turned his head, he could see his shoulder blades. And it's like, you definitely need to be seen, like, knock that off and come in. And I don't remember the injury, I just remember the head rotation and then him being able to, the head rotated 180 and you could see his shoulder blade. It's like, this is bad.
Woo!
This is like real bad.
Yeah, that would be horrible.
Yeah. It was very memorable. It was very memorable.
Yes, if you've taken care of these people, you remember the difference in all the
yes, you
patients.
do.
Okay, penetration caused by a bullet or knife are the examples. So a lot of times they'll still have that bullet lodged and they won't even mess with trying to take it out because that could cause even more damage. All right, so here's the different forces. So this picture is also in your book. Okay, remember if it's a complete, and with the spinal cord damage, that the nerves will not work below the level of the injury. What's this going to do to our patient? It'll be decreased mobility. They won't be able to walk, or decreased sensory perception. They wouldn't be able to tell if their feet were on fire, or their hands, and bowel and bladder control, which, like we said, is extremely embarrassing. Spinal cord injuries. So here's the compression one and then the force one. And you can see what it's done is what it's done with the nerve here. With compression, this one's compressed and this one's just totally fractured. And so it's pinching that nerve there. Some pinching. This is also in your book on page 878 if you're following along. What's that first one you caught earlier? What's the first thing we're going to be worried about? Their ABCs. Airway, breathing, circulation. Because if they're not breathing, that's first on the list, right? Mm-hmm. Indications of hemorrhages or bleeding around any kind of fracture sites or abdominal. Level of consciousness. We're going to use what again? Glasgow Coma Scale. And what is the perfect score on that?
15.
What's the score for a coma? 8. Good. Level of
What's
injury.
the score for death? You can't get below 3. You can be dead and still score a 3. I always found that amazing. Really? You can be dead and still score a 3. Yeah.
Yeah. Level of injury. Tetraplegia. What does that mean? All 4. Kind of like the quadriplegia. And then we could just have paralysis with all 4. Paraplegia and paraparesis. Okay, priority in their care. First of all, respiratory distress and failure. Some of these patients, depending on where it is, they may be on a ventilator the rest of their life. Okay? And so they won't have to be intubated anymore, but they could have a trach, right? And then potential for cardiovascular instability. And that can happen quickly with shock and autonomic dysreflexia. Anybody know what the autonomic dysreflexia is? We'll get there. It's an ugly thing too. Okay, potential for a secondary spinal cord injury, just because they don't have control of things, and if we're not careful, we can also help them get a second injury. Decreased mobility and sensation. I do want to let you know that the autonomic dysreflexia is life-threatening. Okay, planning and implementation. We have to manage the airway, check cardiovascular, prevent more injury, and we want to make sure that we do not move them. Non-surgical management is immobilization and drug therapy. And surgery if they think they can do something to help. And like I said, they may have a bleed in the abdomen. They may have a broken bone elsewhere besides. Home care management. Well, like she said, she worked at Rusk. So the goal is to hopefully be able to get them to home eventually. And self-management education to see what kind of skills and things they can do. I mean, if you think about it, who was the gal that could paint? What's that?
Frida Kahlo.
Could be. I don't know that name. I'm thinking it was a first name it was a lady though, but she would paint with her teeth. She would put that paintbrush in her teeth. Joni Erickson, I think. It's the one I'm thinking of. But they learn how to do different skills and different things and cope. And it's amazing some of the stuff they can do. Pressure ulcer prevention. Okay, so if they're not being turned, they're not being moved, you're going to get those pressure ulcers very easily, right? Who's going to help them take care of that? Who's going to help them? Are they going to feel it? No. Have you ever seen a pressure ulcer that you can put your fist in? Whoa. So how can we tell? By walking in the room, how do you know? The smell. You automatically know. It's a smell you won't forget, just like if you've ever smelled a GI bleed. You will immediately know just from the smell. Thank goodness we have those cranial nerves, right? We can smell the olfactory.
Then we don't have scratch and sniffs.
Oh, well, that's true, but I don't think I want them. It's kind of like
UTI, sniff and scratch.
kind of like the Harry Potter jelly beans, huh? Ugh. Okay. Sorry. Bowel and bladder program. What kind of bowel and bladder program would we do?
Void every 2 hours.
I'm sorry?
Void every 2 hours.
Every 2 hours. They may have a catheter in, and you have to teach the family how to cath them, the family how to take care of them. Sexuality. Do we think, let's just say, for instance, so it was a 25-year-old male had a diving accident. Do we think that he can achieve an erection? He can. I'll never forget. I was probably 20 in nursing school, and I had to go, and I had a spinal cord injury, and it was a 16-year-old male, and he had had a bicycle accident. And this was less than 2 months prior. So, he had a trach, and I was doing full care, and I was doing his bath. And sure enough, I was probably about a size 5 and young and pretty or something like that at that time. And here I was just trying to give him his bath, and whoop, immediately an erection. And I said, and my teacher said, "Yeah, you still have to straight cath it." I said, "No, I can't." And she goes, "No, it won't work." So she goes, "Just hit it with a pencil. Get rid of it so you can go ahead and do your straight cath." I didn't do that. I just did other things until I could go back because I felt so guilty. But yes, they can. They can still. And so that's why you wonder how some of them become parents. Absolutely. So it can happen. But that is still... Okay, so nothing functions below here, but you still got your brain. You still want your spouse to be attracted to you. You still need that love and that support. So that is a big thing. And you also give them different healthcare resources. What else do you think they could use resources for?
Support group.
I didn't hear that.
Support group.
Support groups? Maybe some financial support. They're disabled. They may need to know of different things. They may need to know of different food banks. There's different things for the family. Daycares, different things so everybody can get out. And I'm not going to go on from here. Let's stop that and let's watch one more video. Is that okay with you guys?